Okay, so let's move on and talk about fractures. So a fracture is a disruption or a break in a bone. Okay, so on the left there, you can see a tibia and fibula fracture, a lower tib-fib fracture. On the upper right, you can see a mid-shaft humerus fracture, and on the lower right, you can see a wrist fracture, so a deviated wrist fracture. Okay, all of these are going to need some kind of treatment. Um, some of them surgical, some of them can be actually repaired and casted in the emergency room. So there's a whole variety of potential treatments depending on where the fracture is and how displaced the bone is. Okay, and we'll talk about the different types of fractures. Okay, so let's talk a bit about some common fractures. So the one on the left, a green stick fracture, well, those are only in children. Okay, so a child has a very strong periosteum. Okay, and remember, they're more flexible than adults. We're a bit more brittle. So when we fracture, we typically fracture right through the bone. A green stick fracture is being held in place very well by the periosteum, which is that saran wrap lining of the bone. And typically, it hasn't moved very much. The bone has just bent a bit, and we call that a green stick. You know how you bend a green stick, a green branch? Well, it's the same term here. It just has a bit of bending, and often there's not much to do for these except to cast and immobilize them until they've healed. Well, a spiral fracture is, just as it says, it's a fracture that spirals down a shaft. So you can see that one part of the fracture is higher than the other part of the fracture. And these can be very unstable because they're not transverse. They don't go across the bone. So spiral fractures, like most fractures, they need immobilizing, and sometimes they even need a surgical pin or a bolt to stabilize them. A comminuted fracture is the term where there's more than two bony fragments. So if you look at the spiral fracture, you can say, yep, there's a fracture there, and there's an upper and lower fragment. A comminuted fracture means there's more than two bony fragments. So there's multiple pieces of the fracture, and we call that comminuted. A transverse fracture is just a fracture that goes right across the bone, right, in the transverse direction. A compound or an open fracture is one that has punctured through the skin and now the bone has been exposed to the environment. And that's a problem because bone is really prone to getting infected and leading to infection of the bone. So we really don't like to see compound fractures because we know they're going to have infectious complications. Okay? So the term compound or an open fracture is the same term. And lastly, on the right there, that's just showing you an image of a vertebral compression fracture. So for example, someone who slipped on the ice, landed on their bottom, and the force went up their vertebral column and squashed one of their vertebrae, such as in this image, has a vertebral compression fracture, and that's not going to that's fixed. That's going to stay like that. And they're very painful for weeks to months. Okay? And you can imagine where you've had a vertebral fracture. Well, there's joints on each side of that vertebra, right? So those cartilaginous joints, well, they're prone, that area now is now prone, that area is prone to osteoarthritis because the joint's been injured. Okay. Okay, so let's just talk about a couple of terms with fractures. So, what usually leads to a fracture? Well, a force that's beyond what the bone can tolerate, and the bone just completely fractures through. Okay, so, but there's a couple of other different types of terms that we use when we're talking about fractures. So, what's a stress fracture? Well, those are just tiny, tiny little cracks in the bone that sometimes we don't even see on X-ray initially. And they're just from repetitive force. And they're often in either the foot or the leg because they're weight bearing and they're more prone to stress fractures. So let me give you an example. Someone decides to go for a 20-mile run and they don't do that very often. And they come back with a really, really sore foot, and they may have a stress fracture. If we x-ray the foot, we may not see the stress fracture initially, but often 2 or 3 weeks later, if we were to re-x-ray it, we would see calcification, so calcium deposition on where the stress fracture was. But initially, we don't see it because they're so tiny that they don't show up on X-ray. Okay, so those are stress fractures. A pathologic fracture is a fracture that's occurred because there's something wrong with the bone. So, for example, someone who has a cancer that's spread to the bones, say it's spread to the femur, and they're walking, and one day, because of the weakness in the bone due to the cancer that has spread there, they just fracture completely through the cancerous bone. That would be called a pathologic fracture. Okay. Osteoporosis would be another example of a bone disease where people can easily fracture through because there's demineralization of the bones in osteoporosis, making those areas really prone to fractures. Okay, so an older person can have a fracture of their wrist, of their vertebral column, their hip, from osteoporosis with very minimal injury. So, in fact, some older patients can have a spontaneous vertebral fracture just by standing up because they have such thin osteoporotic bones in their vertebral column. A reduction, that's just a term where we try and bring the bones back into normal alignment. So if someone has a displaced fracture, such as in the image above of that wrist that was very displaced, well, we can try and reduce that and straighten it back to normal. An open fracture I mentioned before is the same as a compound fracture. And of course, a closed fracture is a fracture that's been contained within the tissue. It hasn't broken through the skin, which is always nice to see. Okay, we don't like to see compound fractures because of the risk of osteomyelitis, infection of the bone. Okay, so signs and symptoms of fractures. We've spoken about some of these already, but at a fracture site, there's going to be edema in the tissue. So if you fracture your tibia, which is your lower leg bone, well, depending on how you fractured it, there's going to be varying degrees of swelling and edema in the tissue. Okay, and that can lead to a certain condition called compartment syndrome that we'll talk about a bit later on. Okay, so there's typically edema with fractures. There's pain at the fracture site, right? So bone has a lot of nerve endings. Remember that periosteum that's now been torn and stretched? Well, it's going to be painful. And also, the bony fragments are probably moving a bit. So that's going to be painful. And then around that, there's muscles that go into spasm because they've been injured. Okay. Deformity. So some fractures aren't displaced at all. You can't tell that there's a fracture until you X-ray. But if there's a lower leg fracture or an arm fracture that's where the hand or the ankle is pointing in an opposite direction, well, that's pretty clear that there's likely a fracture, right? There's often bruising with fractures. There's definite loss of function. So someone with a hip fracture or a significant ankle fracture, they can't walk anymore, right? It's too painful, and the bones won't tolerate the weight. Crepitation. Sometimes when we examine a leg and we don't know it's fractured yet, and we're just checking for pulses, we're checking for edema, and the patient moves the leg or we move the leg. They're often not happy about us moving the leg if it's fractured. We might feel some crepitation, which is the movement of the fragments against each other. Okay, so we're not very popular if we're moving fractures that are unstable, because that creates a lot of pain. Okay, so I'll leave this slide to you. We've spoken about all of these. Okay, I don't think there's anything on here. I'm just looking at, so hematoma is a blood collection. The swelling we spoke about, the crepitus, that crunch, that audible crunch. Or sometimes patients will come in and say, I heard something crack when I fell down. Okay. The resizing of an injured area. So someone with a hip fracture, well, when the hip snaps off, the leg is shortened on that side, right? So sometimes if we look at a patient's leg, and we'll see, so not only are they complaining of hip pain, but we can see that their leg isn't as long as the other leg any longer, okay, because the hip has broken off. Okay, seeing an open fracture, well, that's pretty clearly an issue. Those patients typically need to go on to IV antibiotics and head right to the operating room for that area to be cleaned out. And we really try hard for that to happen within hours to prevent osteomyelitis. Okay. The other ones I'll leave to you. I think they should make sense. Okay, let's move on to the next slide. Okay, so just a few images of different fractures. So here's a comminuted fracture of the tibia and the fibula. It's not really that displaced, meaning the bones haven't shifted off that much, but there's multiple fragments. This person definitely will be unable to walk until they receive orthopedic surgery, right? So this is more than just a cast. In actual fact, you can see a cast going around the bones on this x-ray. That would just be temporary until this person could have surgery. Okay, this one's showing a green stick fracture where the bones have just bent a bit, like a green stick. And this is probably 2 or 3 or 4 weeks old because there's nice calcium deposit at the fracture site, right? So that's what we call a callus. And that means that the bone is well on its way to healing. Okay, so let's talk about healing of fractures. So at the fracture site, what happens first? Well, there's bleeding at the fracture site, right? So when you fracture a bone, well, you might have a bit of bone marrow leak out into the tissue. Hopefully it's not an open wound, but you have a collection of blood at the site, okay? And that hematoma is going to be very beneficial because it's going to be the first part of healing. And over the span of days to weeks, typically weeks, you're going to start to have healing from osteoblasts. So osteoblasts within the bone are going to start laying down new bone, okay? And the osteoclast will remove the injured and devitalized bone. Okay, so and that's what's going to form that callus that we saw in the image before. Okay, and that spans weeks. Ossification is where osteoblasts are now creating collagen and depositing more and more calcium to strengthen the bone back to its original strength. Okay, so the callus is just the beginning. Okay, we're going to start to see callus formation typically 2-3 weeks after a fracture, and then the bone will ossify. It'll harden back to its original strength, and that can take months and months. And finally, at the fracture site, you'll probably feel excessive bone is there, and that will need some remodeling, right? So the bone can go back to its original shape with remodeling, and that can take months to years to happen. So for example, someone with a clavicle fracture. Okay, well the first process is they have a hematoma there. So the fracture ends are still loose. And over weeks, if we were to x-ray it, we'd see the start of a callus. And months later, if we x-rayed it, we'd see that the bone has completely ossified. It's completely calcified again. But if we were to touch it, we'd feel the lump there. And then it goes to the remodeling stage where osteoblasts and osteoclasts can try to bring the bone back to its original shape. And that can take years to occur. Okay, that's not to say that it doesn't have full strength again. It just doesn't have the identical feel until it's completely remodeled. Okay, so let's talk about some complications that can occur from a fracture or just musculoskeletal trauma. Okay, and the first one we're going to talk about, and we'll come back to it a bit more, is compartment syndrome. So this typically occurs in a crush injury. So for example, somebody's leg is crushed, say from being run over by a vehicle. Well, that's going to create tremendous amounts of pressure within the tissue because of all the edema that's forming in the different muscle compartments. Okay, so if you remember at the beginning of this module, we spoke about muscle compartments, and if there's a lot of edema within the compartment, it's going to lead to potentially compartment syndrome, where the pressure just has nowhere to go. So it builds higher and higher within that compartment, and it's going to lead to muscle injury because it's crushing the muscle under pressure. It's going to compress the blood vessels in the nerves within the compartment, and that's going to lead to loss of blood supply, not only to the compartment, but to tissues distal to the compartment because the blood vessels are being compressed. So the limb can become ischemic, and the limb will lose neurological function beyond the compartment fracture or compartment syndrome. So It doesn't need to necessarily be a fracture. It could be just a crush injury that's created tremendous edema within the compartment. Okay. Okay, so a fat embolism, that is from a fracture. So it's not just from muscle injury. You need to have a fracture to have a fat embolism. And this is where some of the bone marrow leaks into the bloodstream, and bone marrow is full of fat, and it travels through the bloodstream to the lungs, to the brain, and to the skin. So how do these patients present? Well, they typically present in within 24, 48 hours with shortness of breath. They can present with confusion, and they often get petechiae on their skin, on their upper body. So their neck, their chest, they can get those little blood spots called petechiae. Okay? So if someone has a significant fracture and next day they're short of breath, they're confused, and we see these petechiae in their skin, we think of a fat embolism from the bone marrow. A dislocation. So a dislocation is typically at a joint, right? So say the shoulder joint dislocates. So there doesn't necessarily have to be a fracture. It's just the joint has come, or the bone has come and dislocated out of the joint. And the classic joint for that is the shoulder joint. Okay. Now you could have a knee dislocation. It's pretty hard to do that because you would have to tear through all the ligaments in order for your knee to dislocate. You could have a patellar dislocation. So the little bone at the front of the knee, the patella, can dislocate, and that's usually a relatively easy fix. We just push it back into place. Okay. So think of dislocations as occurring typically at joints. An infection, so osteomyelitis, that typically occurs when a fracture has punctured through the skin and the bone has been exposed to the environment, and it has a high risk of becoming infected. Okay. A vascular injury, say at a fracture site, or a crush injury. What happens? Well, if there's a crush injury, not only does the bone and the muscle get crushed, but the blood vessels and the nerves get crushed, right? So you can have nerve injuries down a limb, you can have vascular injuries, and that's why we always check distal pulses to make sure that there's still a good arterial flow to the limb. And we do nerve testing to see if they can still feel. Say if it's a leg fracture, can you feel when I touch your toes? Vascular and nerve injuries are always checked distal to the fracture. Avascular necrosis of the bone is where a segment of bone has lost its blood supply and that bone dies. So a good example of that is with a dislocation of a hip joint, say. So the hip joint is a ball and socket joint. If it dislocates, it doesn't, the head of the hip doesn't get any blood supply any longer, and that's why we need to get this this dislocation back into its normal position in the hip joint. Because if we leave it out, it's lost its blood supply, and the head of the hip will develop avascular necrosis, and the head of the hip joint will die, and the bone will die with it. Okay, so that's avascular necrosis of the bone. Traumatic arthritis. So if you have a broken bone and the fracture goes into a joint, so say you have a fracture around your knee joint, and the fracture starts in the femur, but it spirals down into the knee joint. Well, that's disrupted the joint and likely the cartilage. So that joint is always going to be prone to osteoarthritis later in life. Okay? So that's why if we see a fracture that's gone into a joint, we tell the patient this fracture is prone to, or your joint is now prone to osteoarthritis because the joint's been disrupted. Okay? So even if we line it up perfectly, there's still a risk for osteoarthritis later in life. Okay? And that's why a lot of sporting injuries, a lot of fractures that go into joints in young people, they develop osteoarthritis later in life in that joint. A fracture may not form a nice callus, and it won't form a good union. So non-union of bone, and there's certain bones that are much more prone to this than others. And what happens is the callus doesn't form, the bone doesn't ossify, and you're basically left with two fragments that just don't heal. And sometimes those need a pin or a screw put into them to hold them together. Okay. And lastly, because of the immobility following typically a leg fracture, such as a hip or a severe ankle injury, or crush injuries to the legs, and you're immobile, well, you're prone to DVTs. Not only because you're immobile, but because the leg has been injured. And when you injure your leg, you've likely injured the veins, and that can lead to a deep vein thrombosis. And if a piece breaks off of the thrombosed segment and travels to the lungs, you get a pulmonary embolus. Okay, so let's talk about compartment syndrome. Okay, so as I mentioned before, it can be a complication of a fracture because of all the edema that forms around the fracture within the compartment, or it could just be from a crush injury. And the bone didn't fracture, but the compartments are now full of edema, and the pressure is rising within a compartment of muscle tissue. Okay? And as the pressure goes higher and higher, it compresses the nerves and the blood vessels, and that can lead to permanent nerve damage distal to the compartment syndrome and ischemia distal to the compartment syndrome. So a compartment syndrome is actually an emergency. That compartment needs to be opened for the pressure to be released. Okay, so this is an orthopedic emergency, and typically we try and get the compartment, once we've diagnosed it, we try and open up that compartment within 6 hours. Otherwise, there's going to be potential loss of muscle tissue because of ischemia, nerve damage because of the compressed nerve, and any distal limb, so your foot or your toes, may become ischemic if you have a leg fracture because the blood is no longer able to get through the compartment because of the high pressures. Okay. So what's the cause of a compartment syndrome? Well, I mentioned it could be a fracture or a crush injury to a limb that leads to that increased pressure. It could be a severe burn around the chest or the abdomen. So if you have a burn that completely encircles your chest or your abdomen, well, you can't take big breaths anymore, right? Because the burn has formed this scarred tissue and it's impeding ventilation. You can't take breaths. So that's a form of compartment syndrome, in that burned tissue needs to be cut open and be released so that the patient can breathe again. And the same thing would apply to a full circular burn around the abdomen and back. It's not allowing the abdomen to expand at all, so that would need to be opened, the tissue of the skin would need to be opened and released to release the pressure. Okay. What else can cause a compartment syndrome? Well, what about a really, really tight cast? So if someone has a cast put on for their arm fracture or their leg fracture, and they get more swelling to the fracture site over the next few days, but the cast can't expand at all. So they get a compartment syndrome from having the cast on their limb. Okay, what do we do for that? Well, we cut open the cast, right? We relieve the pressure that the cast is causing. Okay, so we always tell patients when we apply a cast, if your fingers go numb, or if your hand is looking very pale, or if there's incredible pain under the cast, you need to return. And what we're really telling them is, you may be developing a compartment syndrome, and we would need to cut open the cast to relieve the pressure. Okay. So really think of the compartment syndrome as there's excessive swelling within the tissue. We're not talking about a cast anymore, and that's leading to a compartment developing very high pressure. Or we can cause a compartment syndrome by putting on a cast or a dressing that's just too tight, and as the tissue became more edematous over days, the cast didn't expand, and we actually gave them a compartment syndrome because of the restrictive dressing. Okay, so here's an image of a compartment syndrome in the lower leg. So those two bones coming down are the tibia and the fibula. And with say a crush injury, well, different compartments can be under tremendous amounts of pressure, and if that occurs, you get compartment syndrome in one or two or three compartments. And what's going to happen? Loss of blood supply and neurological injury, so nerve injury because of the high pressures. Okay, so within the compartment, the muscle might die. Anything distal to the compartment could have neurological symptoms and nerve damage, and also ischemia because of the loss of blood supply, because the compartment syndrome compressed the nerves and the blood vessels. Okay, so what symptoms or signs do we think of in someone who might be developing a compartment syndrome after a crush injury or a severe fracture? Well, over the next day or 2 days, they may get severe pain. So what we tell people is, yes, your fracture hurts, or yes, your crush injury hurts, but if you get suddenly increased severe pain, you need to let us know, because that could be the development of compartment syndrome. Okay. What else can happen? So I mentioned the pain out of proportion to the injury. Okay, so that's someone who has, say, a fracture or a crush injury. Yes, they have pain, and then the next day the pain just escalates. That's pain out of proportion. Numbness, so paresthesia is loss of sensation or abnormal sensation to the distal limb. So anything that's beyond the compartment syndrome, you can start to get neurological changes such as paresthesia. The limb can start to look pale beyond the compartment syndrome because of the lack of blood supply. And as the nerve damage progresses, you can get paralysis of the limb because not only are the nerves dying, but the muscles are dying within the compartment syndrome as well. And pulselessness. So there's no pulses felt to the distal arteries. So in this image, you can see someone has a swollen leg, where would we check the pulses to make sure they're intact? At the ankle, right? We would check peripheral ankle pulses to make sure that they still have good circulation to the limb. So know those signs and symptoms of a developing compartment syndrome. I'm going to tell you, once someone has paralysis of the limb or they're pulseless, that's a really bad sign, okay? Because that means that the tissue is under such high pressure that it's squashing the arteries, and the distal limb is now not being fed oxygen or nutrients. So this is an emergency. That compartment needs to be opened, okay? So if the cause is from a cast that's too tight, and the arm or the leg swelled underneath the cast, well, we'll just cut open the cast and relieve the pressure. If it's from the tissue that's become very swollen within the compartment, well, the compartment needs to be opened with what's called a fasciotomy. And that is what's being shown in this image, where this patient has had a fasciotomy to release pressure in a certain compartment. Okay, so let's go into a bit more detail about a fat embolism. So again, this is from a fracture, typically a long bone, such as the femur, the tibia. Sometimes it could be the pelvis. So bones have bone marrow, and when there's a significant fracture, the bone marrow leaks into the bloodstream, and typically within 1, 2, 3 days, what can happen is these fat droplets are embolizing into the venous system, traveling to the heart, being pumped to the lungs, into all the capillaries of the lungs and blocking them up, and the patient develops shortness of breath. These emboli can also travel to the brain, so these fat globules can travel to the brain and lead to confusion, decreased level of consciousness because it's affecting different parts of the brain. And lastly, to the skin, leading to petechiae. Okay, they block little capillaries in the skin, and those capillaries break open and form little petechiae that we see on the skin. Okay, so shortness of breath, confusion, decreased level of consciousness, tachycardia. Why? Well, they're short of breath, so the heart tries to speed up. Okay, plus petechiae to the skin. Okay, how do we prevent a fat embolism? Well, when someone comes in with a fracture, we're not going to move it all over the place and re-examine it multiple times and move the fragments, because that's releasing more bone marrow into the blood. Okay. How do we treat this? Well, it's hard to treat. We typically give them intravenous fluids to try and help flush the bloodstream out. But really, the fat globules have to make their way through the system. Okay, so there isn't really a great treatment for fat embolism, except trying to prevent it.